Good day, I am Kate Ian Amberlis, your student nurse from BSN 2C of NEUSD, and I am here to recite the umbilical catheterization. First is assessment. A timeout should be performed with particular attention to assure that the correct patient is identified and to assess for any contraindications for the procedure. Next is the procedure should be taken inside a radiant warmer to avoid environmental exposure to the infant. And next is for the planning. Equipment should be listed below, or as listed below should be obtained and inspected. Appropriate lab work, if available, should be requested to review. Next is written consent is necessary from the parent or guardian of the neonate after a discussion of the risk, benefits, and alternatives of this procedure if not performing the procedure emergently. Next is flush the catheter with heparin saline to ensure there is no air present in the catheter and to prevent clotting. Next is attach the three-way stopcock to the catheter. Next, equipment, radiant warmer, sterile gown, sterile gloves, cap, and mask, sterile drapes, bactericidal solution, umbilical tape, scissors, scalpel, Irish forceps, non-tooth forceps, umbilical vein catheter, three-way stopcock, IV tubing, needle driver, 3O silk suture, sterile saline flush. For the catheter size, for free term, it should be 3.5 French, and for the term, the size of the catheter should be French 5. And next is for the implementation. First, put a sterile attire, and then the umbilical stump should be undergo preparation with a bactericidal solution and a loop of umbilical tape placed on a junction of the skin and umbilical stump. Next is drape the procedural field with sterile drapes. Grasp the umbilical stump with non-tooth forceps and apply upward traction through straighten the umbilical stump. Take the scalpel and make a transverse out completely through the umbilical stump 1 to 2 cm from the skin to expose the non-dried umbilical cord to aid in anatomical identification and cannulation of the umbilical vein. Next is identify the two umbilical arteries by their thicker walls and the umbilical vein by its position at 12 o'clock and its larger thin-walled appearance. Next is umbilical tape may be tightened to control the bleeding if present. Gently use the Irish forceps to cannulate and dilate the umbilical vein and to clear any thrombus present in the umbilical vein. Grasp the umbilical vein catheter with the Irish forceps and gently introduce the catheter in the umbilical vein. If the clinician meets resistance or loosen the umbilical tape and attempt to advance the catheter again with gentle pressure. And next is if the significant resistance is still present after loosening the umbilical tape, abandon the procedure and seek an alternative method of intravenous access. And if the line placement is for emergency access, advance the catheter 1 to 2 cm past the point of initial blood return. Blood in the catheter, which is usually 4 to 5 cm in a full term. If the line placement naman is for the long-term access, the line should be advanced into the inferior vena cava and just beneath the right atrium, which is usually is 10 to 12 cm in full-term neonate. Next is secure the catheter using a suture through the cord. And after suturing the catheter in place, we need to use tape to create a tape bridge between the abdomen and the catheter for extra protection against displacement. And next is place a transparent dressing over the umbilical stump and umbilical venous catheter. And that's it. This is Katie and Amberlis, your student nurse from BSN 2C.